Welcome to the learning unit on large language models in clinical reasoning. Large language models, in short LLMs, are increasingly present in healthcare education and practice. In this video, we will explore how LLMs can support clinical work and where their use can also introduce risks. We will look at opportunities such as the expansion of differential diagnosis, identification of red flags, and the structuring of care and management decisions. We will also explain important pitfalls, such as hallucinations, overconfidence, premature closure, and cognitive biases, which can influence your work if LLM's outputs are accepted uncritically. It is important to remember that the goal of LLMs should not be to replace clinical reasoning, but to support it and enhance it appropriately. LLMs are AI systems trained on vast amounts of text data. They generate responses by identifying patterns in language, not by understanding diseases or patients. Large language models are not all the same, and it is important to distinguish between general and medical LLMs. General LLMs are trained on very large and diverse datasets, such as books, websites, and general text. They are highly effective at generating fluent language, summarizing information, and structuring text. However, they are not specifically trained for clinical accuracy and may lack awareness of medical priorities and safety considerations. Medical LLMs, in contrast, are trained on healthcare-related data such as clinical guidelines, medical literature, or de-identified clinical records. As a result, they are better aligned with medical terminology, clinical workflows, and professional standards. This can make their outputs more relevant for supporting clinical tasks such as differential diagnosis generation or management planning. However, even medical LLMs are not transparent in how they produce answers, and they can still generate errors or biased suggestions. LLMs can support clinical reasoning by expanding differential diagnosis, especially in complex or unfamiliar cases. They can suggest alternative explanations that may not immediately come to mind and help counteract availability bias. Used reflectively, this can broaden your thinking rather than narrow it. It can prompt healthcare professionals to reconsider assumptions and reflect on uncertainty. However, suggested diagnosis must always be evaluated against the clinical context and available evidence. LLMs can assist by pointing out symptoms, signs, or combinations of findings that may indicate serious or life-threatening conditions. This can help healthcare professionals prioritize further investigations or escalations of care. However, red flags generated by an LLM should be seen as prompts for reflection, not definite conclusions. Another important strength of LLMs is their ability to help with management reasoning, not just diagnosis. Making diagnosis is often about deciding what condition a patient has. Planning care, however, is about deciding what to do next, and this usually involves several options. LLMs can help organize treatment options, follow-up plans, and monitoring strategies. Then they can make the steps behind management plan clearer and easier to follow. Management reasoning also involves the patient. Different patients may have different preferences, concerns, or life situations. LLMs can help prepare explanations and information that support conversations with patients and shared decision-making. For example, after diagnosis such as diabetes is made, an LLM can help generate personalized patient information. This can support discussions about treatment choices and daily self-care. However, LLMs do not know the patient personally. All suggestions must be then reviewed and discussed by the healthcare professional together with the patient. Despite these benefits, LLMs introduce important risks for clinical reasoning. One major pitfall of LLMs are hallucinations. As proposed by Kim and colleagues, here you see a visual taxonomy of medical hallucinations in LLMs organized into 5 main clusters. I will now briefly describe them. First, we have factual errors. Those might be hallucinations arising from incorrect or conflicting factual information. Next, we see outdated references, meaning errors due to reliance on outdated or disproven guidelines or data. Spurious correlations. Here, hallucinations may merge or misinterpret data in ways that produce unfounded conclusions. Fabricated sources of guidelines. Inventions or misinterpretations of medical procedures and research. And lastly, incomplete chains of reasoning, being flawed or partial logical processes. In clinical reasoning, hallucinations are particularly dangerous because they may introduce false assumptions into reasoning process. Every factual statement produced by an LLM must be therefore verified using trusted clinical sources. LLMs often present information in a confident and fluent tone. This can obscure uncertainty, missing data, or competing explanations. Overconfident summaries may lead to healthcare professionals to underestimate diagnostic ambiguity or complexity. Clinical reasoning, however, requires recognizing an uncertainty. Premature closure occurs when healthcare professionals stop considering alternative diagnosis too early and accepts an initial explanation without sufficient verification. When using LLMs, this can happen if a suggested diagnosis or management plan appears plausible and well structured, leading users to overlook conflicting information or additional possibilities. LLMs can also influence cognitive biases in clinical reasoning. One important example is availability bias. Availability bias occurs when diagnoses that are more familiar, recently encountered, or more frequently mentioned are judged as more likely, even when they are not. Because LLMs are trained on large datasets reflecting common patterns, they may overemphasize frequent or well-documented conditions. This can unintentionally push healthcare professionals toward common diagnoses while underrepresenting rare but relevant alternatives. Some other biases could be suggestibility bias, which could lead LLMs to adopt incorrect answers when confronted with persuasive but inaccurate prompts. Confirmation bias, where model beliefs not only skew the reasoning process, but also influence how rationals are utilized for answer prediction. Framing bias, which can affect LLM-enabled systems when the same clinical information presented in different ways leads to different model outputs. Anchoring bias, which can surface in LLM-enabled diagnosis when early input or output data becomes the LLM's cognitive anchor for subsequent reasoning. To summarize, LLMs can support clinical reasoning by expanding perspectives, structuring information, and prompting reflection. At the same time, they introduce risks that require critical awareness. Students and healthcare professionals should act as editors and interpreters, not passive users. This means verifying outputs, contextualizing suggestions within the patient's situation, and reflecting on how the tool influenced reasoning. Thank you for watching.